Recording. And welcome everybody to our CAPPI Chat. So this is a public lecture from the UAB Center for Addiction and Pain Prevention and Intervention. I am going to be speaking today on diets for pain. I'd like to keep it very informal. People that know me know that I can talk nonstop for a long time. So please do just interrupt if you have any questions. It's hard to follow the chat while I'm talking. So just go ahead and unmute yourself and ask a question if you want. I thought this would be perfect for after the new year and right at lunchtime. So if you're eating lunch, hopefully this doesn't put you off. All right, so this is just sort of a quick outline of where I want to go. So we're going to talk a little bit about obesity, how it's related to health and pain, inflammation. We're going to talk about diets, how diets are related to inflammation and how they can increase and decrease pain. And then I'm going to end talking about different types of diets and what has been done with respect to pain. So the first thing I want to just mention, and I like this little cartoon, seems very ominous. Obesity is a worldwide problem. I mean, we often think of this as sort of an American or a North American issue, but it isn't. It is a worldwide thing. And so what you'll see on this little cartoon is as the colors get darker, that is a greater percentage of the population that is obese, so has a BMI above 30. This ends, I think, in 2014, but you can see a lot of the world is pretty dark there, which is a very apt metaphor for right now. But essentially, you know, this is a big thing. So generally, obesity or just excessive weight gain is the result of just having too many calories than you're burning. I often tell students to think of this as sort of a simple way. If you think of your body as a machine, the energy put in should equal the energy out. And that will keep you at essentially the same place. So if you are eating as many calories as you're burning, your weight should stay roughly the same. If you're eating twice as many than you're burning, then you have an excess. And that excess gets stored. It gets stored as fat, and that's where weight gain is happening. On the contrary, if you want to lose weight, you can do that either by decreasing the energy in, so cutting your calories or your food, or you can increase the energy expended. Both of those will lead to a deficit, and that will then result in weight loss. So, of course, adding weight is going to increase pressure on the joints, and so that is going to have an effect on pain. But obesity itself is pro-inflammatory. And so from this study, they took individuals that were either normal weight or obese, and they just looked at one of these inflammatory markers. And what you can see pretty clearly is the individuals that are obese that have no pain have a higher level of these inflammatory markers. And so just being obese resulted in this sort of system-wide inflammation. So, well, what is inflammation? Most people do have a good idea what inflammation is, but usually it has to do with an injury. So if you have, twisted your ankle and you have that inflammation, people will recognize that for what it is. But there are sort of these 5 pillars of inflammation. And so heat, so the area may feel warm, it'll be red, you'll get swelling happening, there'll be pain or hypersensitivity associated with it, and there will be a loss of function. Now, loss of function doesn't mean that you'll never use it, but if you have twisted your ankle, you can't use it the way that you used to. And so there is a decrease in the function. And so when you try to associate pain and inflammation, what you can do is think about what you take for pain. So if you have a headache, if you have a backache, if you have sore muscles, you recognize that as pain. And if you look at the sorts of things that people take for pain, those things are things like aspirin, Aleve, Advil, Tylenol. All of those things are over-the-counter medications that we take for pain. All of these medications are anti-inflammatory. So they reduce pain and they have this anti-inflammatory property. And so you can see how that link is pretty easy to make. Now, obesity is pro-inflammatory, but it also increases the likelihood of experiencing pain. And so in this graph, what this is showing, this is in a number of people, thousands and thousands of people across the US, and they essentially asked what their height and weight was in order to categorize them as different levels of obesity, and asked them whether they had pain yesterday. So, looking at what your odds of having pain yesterday were, what you can see across the ages and across the sexes, as the level of obesity goes up, your odds of having pain yesterday also go up. And so that should be pretty clear here. So individuals that are morbidly obese have a much higher likelihood of having pain yesterday or having pain. Now, if we look at opioid use, because this is CAPPI and this is my one little addiction slant. If you look at opioid use as a function of BMI or obesity, you can see some similarities there. So the picture on the right, this is percent of adults in every state that meet the criteria for obesity or have a body mass index higher than 30. And you can see it tends to be sort of concentrated on the south and in the west and on the east, a little bit in the central part of the US. Now, on the left, you see opioid prescriptions per 100 people. And you can see that there's a good deal of overlap there, where the states that have the higher levels of obesity tend to also have the higher levels of opioid use. Now, again, it's sort of a connection that we can try to make, that the individuals that do have obesity tend to also have pain or vice versa. So it does make sense that increased weight might predispose you to having pain in a weight bearing joint. So in the knees, the ankles, and things like that. But people who are obese are also more likely to have pain in non weight bearing joints. So things like the fingers or the neck. And so it seems like there is something more to it than just simply being obese. And we think, of course, that it's diet. So generally, foods that are bad for us also taste good. So things that are considered desserts tend to not be terribly good for you. They tend to be high in fats and sugars and are relatively inexpensive. It's very easy to get a meal for under $5 if you go to a fast food joint. Also, food labels can be misleading. Now, it's not that the food labels are lying, but it can mean different things. So if a food label says the word light on it, this can mean it has 50% less fat, it has a third of the calories, it has half of the sodium, or simply just less color or texture than a reference food. So just because you're buying a food that is light doesn't necessarily mean that it's better for you. It just might be lighter in color. And so it's not that that is a lie, but that term doesn't always mean what we think it does. Now, we've done some studies in lab animals looking at diet, and this is just from one of those studies. If we give animals an American diet, so it's high in processed carbohydrates and fats, these animals get fat, so we get obesity, and they get inflammation, even in the absence of pain. And so, what this is simply showing is that these rats that are the red bars had higher levels of all of these different inflammatory molecules than the animals that ate the normal diet, which is the open bars. And so this is just showing, in the absence of pain, eating a poor quality diet increases inflammation. Now, in humans, we see the same sort of thing. So the study that I'm showing here was in fibromyalgia patients. And so what they did in this case is they took fibromyalgia patients and they asked them what their diet looked like. And when they did that, they were able to calculate a dietary inflammatory index. So, how much of their diet is contributing to inflammation. And then they looked at how sensitive they were to touch in different parts of their body. And so, what you're seeing here are the thresholds. So, how much pressure does it take to cause pain in these different areas? And the four different columns coincide with the levels of this dietary inflammatory index. So, the far right are the people that are eating the most inflammatory foods. And so, what you can see across all these different areas, and we're not going to go into them in any detail, is that generally, as your diet is more inflammatory, your thresholds go down, meaning that you're more sensitive to touch. And so the idea here is that the diet seemed to be related to how sensitive these individuals were. Now, pain doesn't just have to be chronic pain. After an injury, we also have pain. Now, that injury could be something sustained accidentally, it could be surgery. Any of these things can cause pain. Now, pain itself after an injury is adaptive. It's the way that your body can help you protect that area while an area is healing. So, if you have twisted your ankle, you get swelling and redness and pain and hypersensitivity in that area because that area needs to heal. And so, if there's pain there, you're less likely to use it, you're less likely to re injure it, and it helps you to heal and protect that area. But your diet can also affect recovery. So, in studies of trauma patients, the level of obesity is also related to recovery time, to the point where your recovery rate is worsened by 4% for every increase in BMI of a single unit. So if your BMI is 10 points higher than normal, that's a 40% decrease in your recovery rate. So that's a pretty major thing. Now, in some young Canadian athletes, they also looked at level of obesity and the amount of time it took them to recover from sprains and strains. And what they see again is that the level of obesity was related to how fast they recovered. So the individuals that were higher in obesity took much longer to recover from that injury. And we've modeled something very similar in laboratory animals multiple times. In this experiment, we had animals that were eating our American diet or the regular diet for a number of different weeks. We caused a short term inflammatory injury, and we're looking at their sensitivity to that injury. And so on the left hand side, you can see less sensitive are higher numbers, more sensitive are the lower numbers. And so for our control or our regular animals, they are hypersensitive after the injury. That sensitivity lasts, that maximum hypersensitivity lasts for about 7 to 9 days. And then they start to recover, and they're fully recovered by day 26. Our animals that get the American diet, they are maximally hypersensitive for almost 2 full weeks before we start to see any recovery. And it takes them 40 days before they come back to normal. And so, just like in a bunch of our other studies, this sort of an American diet almost doubles the time it takes to recover in these animals, which is something that we also see in humans. So, knowing that obesity and diets can affect pain, why aren't they used more as treatments? Well, it comes down to the fact that people don't think that their diets are bad, even when they are. So, this was a really interesting study that came out last year. This was a cross sectional study, which just means they asked people once. These were chronic pain patients, and they were asked to rate their diet on a scale of terrible to excellent. And most of them rated their diets as either good or excellent. Now, they also asked them to actually report what they ate in the last 24 hours. And what they found is that even when they reported that their diet was good or excellent, it rarely was. And so now this could have to do with knowledge. It may have to do with just not really understanding what a good diet was, or just not believing that their diet was as bad as it is. Also, they didn't feel that their diets had any impact on their pain. So when asked, when you eat foods that aren't good for you, does it change how you feel? They didn't believe that it did. So what foods can we use to reduce pain? So we're going to look at a few examples of individual foods, and then we're going to look at diets. The first one are the omega-3 polyunsaturated fatty acids. And I start here only because this is the one that most people are familiar with. So eating things like avocados and walnuts and salmon and olives and olive oil, and you can see the little capsules there. So people take omega-3 supplements or fish oil supplements. Omega-3s are very beneficial. If you incorporate them into your diet, lots of studies have shown that you can reduce inflammation. In mouse studies, if you treat mice with omega-3s, you can reduce the development of arthritis. You can change the age-related changes in pain sensitivity, so it seems to have a protective effect. But what about humans? Well, this study that I wanted to show, it looked at individuals with rheumatoid arthritis. They were given supplements for 24 weeks. So they were told to eat their regular food, but also take these supplements. And they looked at pain and swelling. And so what the graph is showing is the number of tender joints. So how many joints on your body are tender? And this is the change. So a change of 0 means that everything stayed the same the whole time. So the first group in the open circles got olive oil. So olive oil can be very beneficial. They had 9 capsules of that a day, but generally their pain stayed roughly the same. So there was really no change in number of joints. Low dose omega-3, so they had capsules that specifically had higher levels of omega-3s. They took about 7 a day based on weight. And you can see that by 12 weeks, they were starting to see reductions in number of joints. And so you're getting 1 to 2 less tender joints after 12 weeks, and that tended to persist for the study, down to about one less every time it was assessed. If you doubled that dose, so these people were taking roughly 13 to 14 capsules a day, even by 6 weeks, you start to see a significant decrease. So 1 less joint. By 12 weeks, we're down in the 2 to 3 range, and it stayed at that level, around 2 less tender joints throughout the study. Now, what's interesting here is that the study lasted for 24 weeks, but they assessed them 12 weeks later, and the individuals with the high dose still were low 12 weeks after the study ended. Now, what about grapes? Grapes and wine, we're told, is very good for inflammation. Grapes do contain compounds that are called polyphenols. They essentially give it the color and the smell. A lot of the work that's been done looking at these compounds has been done in animals. One of the main compounds is resveratrol. That's been tested in a whole bunch of different conditions, and we know that it does tend to reduce inflammation. It suppresses part of the cells in your immune system. It's an antioxidant, and it can reduce pain. One of the studies that has looked at some of these polyphenols asked individuals with pain to consume bilberries. Now, bilberries are shown here. They're very similar to a blueberry, but they're found in Northern Europe. After 8 weeks of eating these bilberries, so around a cup a day, you saw a decrease in inflammation. So these supplements can help and can reduce inflammation. Now, eating a cup of blueberries a day may be okay, but a lot of people can't always sustain that. And what about green tea? Green tea's been consumed for thousands and thousands of years. EGCG is the active ingredient in green tea that's thought to have all the beneficial effects. Now, there has been a lot of work on EGCG, specifically at UAB, looking at how beneficial it is for cancer. But the work that's been done on green tea and pain has primarily been done in laboratory animals, and it's found to be good at reducing pain and inflammation. There was one study that was done in humans that looked to see whether supplements of EGCG would have any detrimental effects, And so they gave people 4 capsules a day for a number of weeks and found that there was really no negative side effects associated with that. And so that was the equivalent of 8 to 16 cups of green tea a day, which sounds like an awful lot. But they do report that some cultures will consume up to 20 cups a day, which sounds like an awful lot. But again, the idea is that a decent amount of this can be consumed with no real ill effects. Ginger is also one that I thought I would highlight just because it is something that people do take on occasion. We know that ginger and some of the compounds that are found in ginger have direct effects on the pain system and directly activate or deactivate some of those receptors. In lab animals and humans, ginger has been shown to reduce inflammation and pain. This study that I'm showing here, these are adults with knee osteoarthritis. They're given 4 weeks of a ginger supplement or a common non-steroidal anti-inflammatory drug, diclofenac, which is, what was it again? I forget. Voltaren or Cambria, or I think are the common names. But what you're seeing here is the pain visual analog score. So on a line between 0 and 10, how much pain are you experiencing? And of course, a decrease means that there's less pain. And so what you'll see is that both are similar. So this sort of common anti-inflammatory drug is just as good as a ginger supplement. So again, this shows that anti-inflammatory and pain-reducing quality of these supplements. So there are foods and food compounds that do have direct effects on pain and inflammation, but what about whole diets? And so the first thing I want to mention is that there are a ton of diets. You can go online and find any kind of diet that you can imagine. My favorite here is the taco cleanse. That sounds like it would be a fantastic diet to try. But there are lots of different diets. So some of them have a decent amount of evidence. Some of them don't. So a miracle diet that lets you lose 10 pounds in one day, that is not a good diet, and probably involves some sort of surgery. But intermittent fasting diets, the ketogenic diet, plant-based diets, those have a decent amount of data supporting them. But there are lots. And so we're going to go through a few of them. But I wanted to just mention that there are some things to keep in mind here. First of all, not all diets work for everyone. So I have done some studies on diets, and I'm a proponent of one specific diet, but you have to realize that not all diets will work for everyone, and not all diets work, period. Some of the ones on that last screen, I would doubt if they work at all. Now, the other thing to mention is that when advertising diets, extreme examples are the ones that people want to show. They want to show dramatic weight loss. They want to show all these positive effects, but those are not typical results. When you are reading testimonials, a lot of the times these success stories also incorporate exercise. So I didn't want to put a slide up with Jared from Subway because of his legal issues, but he was touted as someone who ate these subs and lost all this weight, but he also exercised a whole lot to get that weight loss. And so even though the subs are touted as the thing that caused the weight loss, burning 2 to 3 times the number of calories a day also has a big impact. So the first are the weight loss diets. And so most of the time when people think about diets, these are the sorts of diets that they're talking about. So either reducing calories or portion sizes, these are aimed at losing weight. And again, thinking of that sort of machine model, you're decreasing what's going in and either keeping the energy expenditure the same or increasing it. So Weight Watchers is a great example of that, and it works very well as a weight loss diet. But a lot of times in a lot of these studies looking at weight loss, you see reductions in pain that happen before there's any weight loss, or at least significant weight loss. And so this suggests that it's not necessarily the weight loss that's responsible for the reduction in pain. Then, as we get to more specific diets, and I'm not expecting anyone to be able to read all the stuff on here, um, but as we get to the more specific, the ketogenic diet is one that a lot of people know a little bit about. This is a high fat diet that is very low in carbohydrates. And the purpose is to get your body into ketosis, where it starts burning fats for energy as opposed to carbohydrates. Now, this is very similar to an Atkins diet. So, an Atkins diet generally is aimed at some sort of ketosis, but not all versions. The ketogenic diet is used clinically. It's very effective for childhood epilepsy that's very hard to treat. There's been a lot of animal studies that have looked at the ketogenic diet and shown that it reduces pain and inflammation, but there hasn't been a large human clinical trial on pain patients yet. So we don't know for sure how well this will work in people for pain. Now, a version of that is the low carbohydrate diet. So this is similar to the ketogenic diet, but it doesn't require ketosis. And so the carbohydrates are reduced, but you're not necessarily looking to see whether you are in ketosis or not. And so essentially, you're just limiting the consumption of carbohydrates, the sugars, and processed sugars. We did a study looking at low carbohydrate diets. We recruited adults with knee osteoarthritis, and they were asked to either follow our low carb diet, a weight loss diet that was similar to the USDA diet, or to just eat normal for 12 weeks. During that period, we measured pain, we measured quality of life, blood markers, all that sort of thing. And some of the takeaways were here. Both of the diets reduce weight. So both the USDA diet and the low carb diet, shown here on the left-hand side, significantly reduced body weight. So around 20 pounds over that 12 weeks. But when we looked at the pain, so we did evoked pain tests. So we had people with knee pain sit in a chair and stand up repeatedly 5 times. And if you've got knee pain, you know that that isn't terribly pleasant. The other thing we did that sounds cruel is we poked them in the knee 10 times to see how much pain that caused. And what you can see here, this is the change in pain over the course of that diet. And what you can hopefully notice is that only the green bars are way, way down. So that's showing a reduction in pain following those tests with that low carb diet. So even though the USDA diet lost weight, it didn't change the kind of pain that we were evoking. Now, the other thing we looked at was a measure of oxidative stress, which is linked to inflammation. And the short here is that only the low carb diet showed that reduction in oxidative stress. And that reduction tended to be related to the reduction in pain. So the greater reduction in oxidative stress that you saw, the greater reduction in pain as well. And so there seemed to be a link there. Now, another diet that people use from time to time is the low FODMAP diet. And FODMAP stands for fermentable oligo, di, and monosaccharides and polyols, which is why they call it a FODMAP diet, because nobody wants to say that. This is a diet that is focused on reducing the sort of food compounds that do ferment and can cause inflammation and GI issues. It is a diet that's often used as a treatment for irritable bowel syndrome or IBS. One study did look at pain patients, so individuals with fibromyalgia and IBS. They gave them the low FODMAP diet and found that they did see a decrease in pain and also a decrease in gastrointestinal symptoms. And so it did seem to treat their IBS, but it also seemed to reduce their pain as well. Now, there's also the Mediterranean diet. So this is a very commonly discussed diet because of all of the work that has been done with a number of different conditions, specifically cardiovascular disease. So this is based on foods that are often consumed in the Mediterranean. And the idea is that in the Mediterranean, the levels of cardiovascular disease and obesity tend to be lower. And so eating those type of foods may have something to do with that. So this diet tends to be very high in fish, vegetables, vegetable oils, nuts, and seeds. Uh, there's a ton of data looking at cardiovascular disease and metabolic syndrome with the Mediterranean diet, and they do seem to be very, very good at that. There haven't been a lot of studies looking at the Mediterranean diet and pain, but there are a few, and I've listed them here. It does seem that the Mediterranean diet does decrease pain associated with rheumatoid and osteoarthritis. So there does seem to be pain reducing qualities of the Mediterranean diet. Now, the last sort of diet plan that I want to mention are vegetarian or vegan diets. And so essentially a vegetarian diet is just the elimination of meat from the diet. A vegan diet is the elimination of meat and any animal product, including eggs, milk, that sort of thing. There are not a whole lot of studies looking at these diets. But again, there are a few, and I've listed them here. So in one study of rheumatoid arthritis patients, they ate a vegetarian diet for 4 weeks, or sorry, in over a year, but within the first 4 weeks, you saw a reduction in pain. 2 studies have looked at a vegan diet, a very strict vegan diet, and seen that it reduced pain in fibromyalgia and in rheumatoid arthritis. So there does seem to be some benefits there, but a lot of the benefits that they saw were very closely tied to adherence. So people that followed the diet more closely saw the greater benefits. So not that I haven't already been on a soapbox, but I want to jump up on my soapbox one more time. So this was a study that came out a number of years ago that simply looked at the consumption of carbohydrates and fat in the American population since the 60s. So this is taken from large nationwide surveys. And what you can see is that there was definitely a shift in the percentage of the diet that was fat and the percentage that was carbohydrate. Whatever's left over is protein. Now, what was interesting is when you start looking to see what happened at these different time points. Well, in 1961, the American Heart Association suggests that we should reduce our total fat. The idea that this would be beneficial for cardiovascular health, reduce plaque buildup, and stuff like that. And so the fats are starting to decline in the diet. One of the major things that happened in 1977 is a US Senate committee suggests that fats should make up less than 30% of your kilocalories per day, and carbohydrates should be roughly 55%. And what you can see after 1976 is that things are starting to move in that direction. So fats are decreasing, carbohydrates are increasing. And then in 1992, I remember seeing this as a kid. The food guide or the food pyramid came out, and that was showing you that you should be eating lots of breads and cereals, a decent amount of fruits and vegetables, but limiting some of these other foods. And so that pyramid was in 1992, again, aimed at hitting those targets. Now, if you look at the same time period and the same data, and you look at level of obesity, you'll also see something very striking there. So after 1977, when the diets shifted, you also see the biggest increase in overweight and trending towards obesity in the population. And so BMI went up almost 2 points for both males and females after 1977. And so when that diet started to shift towards more carbohydrates and less fats, we start to see BMI going up quite a bit. So another little thing to think about. Now, this, of course, are not all of the side effects, but I thought just to sort of put the nail in the coffin, so to speak, for a low carbohydrate diet, these are some of the common side effects. In the first week, people sometimes experience flu-like symptoms. There may be constipation, possibly bad breath, a decrease in appetite, increase in energy. You reduce your risk for cardiovascular disease and metabolic syndrome, and usually weight loss. Opioids, some of the possible side effects: addiction, constipation, very, very common, drowsiness, nausea, euphoria, respiratory depression that can lead, of course, to overdose deaths, and confusion. Non-steroidal anti-inflammatory. So these are your over-the-counter pain relievers. Indigestion, stomach ulcers, drowsiness, headache, dizziness, allergic reactions, nausea, bloating, gas. Essentially, what I want to point out here is that all of the side effects for the opioids and NSAIDs would be considered negative side effects. That's not the case for a lot of these diets. Certainly, there are some side effects that would be considered negative, but generally the side effects are positive. Increase in energy, decreasing your risk for some of these other diseases, and weight loss. So, to sort of sum up, obesity is a pro-inflammatory state, and that can predispose people to developing chronic pain or enhancing their chronic pain. Different foods that are part of the Western diet can have a pro-inflammatory effect and can make pain worse. Foods are known to have anti-inflammatory effects, but in some cases, the doses have to be pretty high. So consuming 20 cups of green tea a day is doable, but may not be likely for a lot of people. Diets do have the ability to reduce pain and inflammation, and we've seen that across a number of different conditions. But just like any treatment, you get more effects if you're closer adhering to that diet. So just like any other sort of a treatment, the better you are at sticking to it, the greater the benefits. And again, my thoughts: diet should be considered as either an alternative treatment or at the very least a complementary treatment for chronic pain. And so with that, I want to also just mention one thing before I end. I think the diets are a great way to moderate pain. But before you try changing your diet significantly or taking any supplements, do talk to your doctor. I feel like a PSA right now, but that is true. There are a lot of medications and supplements that can interfere with medications or conditions. And so do talk to your doctor before you try anything like this. So with that, I will take any questions that anybody's got.
Robert, can I ask a question?
Of course.
I really enjoyed your talk. The problem with the caution at the end is most doctors have no idea about nutrition. So, and they may feel compelled to give an answer when they really don't have the background knowledge to really be, to make any sort of advice that might be useful to the patient. So that's a,
yeah, that's absolutely true.
They're so poorly trained in medical school with nutrition.
Yeah.
I think they get 2 hours over the course of their medical training. So,
well, they get about 10 in pain. So between the two, yeah, no, that's absolutely true. I always caution people to talk to their doctors because I don't think anybody should be doing any radical changes without some consultation, but with that additional caveat that they may just not know. But somebody with a medical degree should be monitoring you.
Hey, Robert, Peter here.
Hey.
One thing I've always thought is interesting, it must be frustrating for the average American to sort of get a sense of really what is the best diet. Because unless you really have a keen eye and can dig into the literature and evaluate the higher quality studies from perhaps the lower ones, you're left wondering, well, or left thinking that there's really no consensus on what might be best. So what in the world do I even do? Beyond just sort of eating less and trying to exercise more. So I mean, I wonder what like practical advice might be for someone who might find this all confusing.
Again, I mean, as much as, we like to sort of tout the diets that we're studying, I mean, you sort of hit the nail on it. Eat foods that are more natural and exercise. The less processed foods that you get, the better it's going to be. And I mean, again, sort of think of it as a machine. I mean, if you're eating 2,000 calories and burning 1,000, you're going to be putting on weight. So, look at it at that level. And yes, I mean, you're absolutely right. I mean, there are a billion different diets out there and they all have success stories. And so it is very confusing. But yeah, I would say in general, reduce the processed foods. Increasing fruits and vegetables is almost always going to be a good idea.
Can I jump in, Rob? Sorry.
Yeah.
I have a cooking well answer for you. Hi, Peter. I'm Larissa. I'm his grad student, but I also work with a nonprofit called Cooking Well, which we do practical culinary and nutrition for the community. And usually the way we like to talk about it, I don't know if this would also help, is we think about our bodies as an odometer. And so whenever we eat something, does it speed up or does it slow down? Do I feel like I need to take a nap and like I can't get through my day and I can't focus and my pain's worse and all these things? Or do I feel like I can, do all the things that I want and live the kind of quality of life that I want, that's good? I can go outside, play with my kids, I can do all these things. So that's, given that diet affects everybody differently, everyone's odometer is going to be slightly different. So that's why we need to kind of use that analogy of really being mindful of what you're putting in and seeing how your body feels, right after and, 6 hours after. And then if it feels good, keep eating that way. If it doesn't feel good, start looking into why it might not feel great.
Can I just, so I've been in this field for 30 years almost. I hate to say it. And what I can say definitively is the prescription to eat less and move more does not work. Certainly doesn't work long term, because you're asking someone to do two things that are unnatural. You're asking them to be hungry, and at the same time, you're asking them to burn more calories. And people can only sustain that for a fairly short period of time, no matter how motivated they are. And the problem is when people fail at that, we blame them for being unable to do two simple things, but these simple things happen to be unnatural. So, and the slide that Robert had when he showed low carb, it decreases your appetite and increases your energy. So it does the opposite of what a typical calorically deprived diet does. And it actually is easier to sustain because of that. So I just wanted to underscore that.
I was going to sort of piggyback on Kevin's statement too. And was it Larissa? Thank you. That was a really interesting comment you made. I think the thing that I think about often, and note, I'm not someone who studies diet or obesity, but when I think about like a treatment or a new drug, the FDA might have the data, or we might have data on effectiveness or safety, but ultimately what will matter to the individual is what works for them, regardless of what the aggregated data might say, which is sort of fascinating. And but for what it's worth, I will say that introduction ketogenic diet, at least for me, was sort of life changing. It's kind of it's almost miraculous how easy it is to do, and the benefits. So personally, I could say I'm biased. It would be really interesting to see more work in that area specifically. But I do think also there's something to be said for whatever might work for the individual, regardless of what ultimately the larger data might indicate. That's all.
Yeah, I think that's a great point. And I mean, that's something that we try to underscore. I mean, part of the the benefits of, something like a ketogenic diet is you are sort of forcing your body to burn that fat as a source of energy. But if you don't have those fat stores, then it makes it a little bit more difficult to follow that. Now, some of us, like myself, are blessed with lots of that. So we've got lots of those stores. But individuals that don't have those fat stores, that can be a lot harder to follow, because they just won't have that energy, those energy reserves. And then you can start breaking down muscle, and that's not good.
Yeah, but the keto is the opposite problem. You can't eat enough.
Yeah.
So.
Any more questions, comments?
So Rob, what's next with respect to diet in your research?
Well, we are doing a study right now that is looking at seeing whether there are racial differences in the effect of the low carb or the USDA diet. Specifically, right now we're just looking at the low carb diet in women with knee osteoarthritis pain, and seeing whether we have any racial differences there. We're also hoping to do a much larger study looking at not only racial differences, but sort of comparing a USDA diet and a low carb diet for pain in the knee, and just seeing what happens, which people it is beneficial for. And I mean, just like we've been talking about, trying to figure out, are there ways to predict who is going to benefit from which diet? Because again, I mean, failing at a diet is tough, and it is often that individual is blamed for that. And so if we can sort of get to the point where we can say, based on these things, this diet may work best for you, that would take a lot of the stress off.
I know in those trials, do you control for calories?
If we're doing the USDA diet, we try to reduce their calories. And so it's, we sort of look at what they're eating naturally and try to reduce that. For the low carb diet, we don't pay as much attention to that, partially because of, what you had mentioned. Their appetite goes down, and you don't want to force people to eat if they're not hungry.
Well, it's interesting in this context, right? Because you've shown that it's not the weight loss per se, at least in some studies, because one of the criticisms you'll get is, well, they're on different calorie levels, and that's why the diets had a different effect. But
Yeah.
if you show that it's not the weight loss, then I think they can't really refute it with respect, because calories is the default for every reviewer.
Yeah. Yeah, and I mean that's what makes, some of these studies very powerful, especially when you get equivalent weight loss in both groups, but you only see a pain benefit in one. I mean, that sort of eliminates, to some extent, that argument that it has anything to do with weight loss. And I mean, we're looking at a weight-bearing joint, but we're not really seeing a decrease in pain just due to the weight loss.